So this is what you've missed. So if you haven't seen the Women's Health Inequality and Social Determinants of Health, then you can see those recorded. And last week's was the reproductive health and maternal well-being. So today we're looking at the other end of life. We're looking at the elder group of women with menopause, hormonal health, and pelvic well-being. We've got 3 fantastic speakers. And we should just be ready to start. If I can introduce our first speaker, who is Lucy Dwyer. Lucy is a nurse consultant based at the Worrell Unit, which is the largest urogynecology unit in the country. And she is also an NIHR research fellow and has completed some very interesting research on self-management of pessaries for prolapse. And that's what she's going to talk to us about today. So I'm going to hand over to Lucy for her presentation. Thank you, Lucy.
Thanks so much, Fiona. Can I just check you can see my slides? I think I was muted there. Can you see my slides?
Yes, we can see them.
Perfect. I'd like to start by thanking Lindsay and the BRC team for inviting me to share my research with you today. I'm really excited to do so. As Fiona mentioned, we received an NIHR clinical doctoral fellowship to look at understanding factors which affect willingness to self-manage a pessary for pelvic organ prolapse. I've been recently appointed as a consultant nurse in urogynecology, and this work was supervised by Professor Dawn Dowding and Dr. Rona Carney. So I thought it would be helpful to talk a little bit about pelvic organ prolapse, because while it is a very prevalent issue, I'm conscious of the fact that it's not a very often discussed issue. So the female pelvic organs, so by those we mean the bowel, the bladder and the womb for people who haven't had a hysterectomy, are supported by muscles, connective tissue and the pubic bones. And this complex system is often known as the pelvic floor. And injury or dysfunction through various different causes can lead to insufficient support and therefore prolapse. So prolapse is defined as the downward displacement of the uterus, vaginal compartments and or the bladder or the rectum. And this prolapse can cause severe impact upon women's quality of life through discomfort, bowel and bladder symptoms, negative self-image and sexual dysfunction. And here's a couple of images of different types of prolapse. So you can see in the first image, the bladder's bulging downwards, so the front wall of the vagina comes down. In the other image, the rectum, and so the back wall comes down. And in the final image, that would be middle compartment prolapse, so the uterus is coming down. Or as I said, in women who've had a hysterectomy, the scar from where the womb was removed can also come down. And we know that 10% of UK women will have prolapse surgery at some point in their lifetime. This equates to over 25,000 prolapse operations during 2015 to 16 in the UK alone. However, we also know that many women with prolapse do not seek treatment or have non-surgical management, which is less well recorded. Therefore, the actual population of women who do have prolapse will be much higher than that 10%. And in a study in America where women were attending a gynecological appointment, 37% of them were found to have prolapse upon examination. So you can see it's a very prevalent issue. As well as surgical management, which I've previously discussed, a pessary can be used to manage symptoms. So a pessary is a medical device. So I've got one example of it here, which can be inserted into the vagina to provide that mechanical support that the pelvic floor is no longer able to. And pessaries have long been used throughout history, with examples of pomegranates being used in ancient Greece. And they have been found to offer equivalent improvement in symptoms to surgery. And pessary management of prolapse may be particularly desirable for women who haven't completed their family, are unfit for surgical management, or who would prefer to avoid the risks of surgical management. And as I mentioned, pessary management isn't very well recorded, but in a service evaluation in 2019, almost 60,000 pessaries were inserted or renewed across just 81 organisations. And because it's only a snapshot of the organisations inserting pessaries, the actual number will be much higher. Pessary follow-up care is provided in either primary or secondary care. And we know that this is really important because the lack of regular follow-up increases the risk of serious pessary complications, for example, where the pessary can rub through into the bowel or the bladder and cause a fistula. And so pessary follow-up in the UK tends to be every 3 to 6 months. This need for regular follow-up of pessaries has been cited as a reason why women opt for surgical management. So at the moment, women need to come to the hospital or sometimes secondary care. The nurse will remove the pessary, perform a speculum examination, and then put the pessary back. And this type of care also denies women autonomy in how they use their pessary. So, for example, if women aren't supported and taught how to do this, they can't remove the pessary if they wish to have sex. It means that they can't just use their pessary at a time when their prolapse is most problematic. For example, if they only want to use it when they're exercising. And a potential solution to both of these issues may be pessary self-management, where the woman is taught to remove and reinsert her own pessary. So the top study was funded by the HDA to explore the clinical cost and cost effectiveness of pessary self-management. And the findings have now been published. And these findings show that pessary self-management reduces the risk of pessary complications and is cost effective. And pessary follow-up can be safely reduced from 6 to 18 months for self-managing women. So you can see the clear resource implications there. However, when I was working on recruiting women to this study, I was really interested in the fact that a large number of women would not even consider participating in the study. And when we looked at this, over 1,400 women declined participation in Topsy. And for 33% of them, this was because they had a preference for clinic-based care, compared to just 6% who had a preference for self-management. And I thought this was really interesting because when self-management of other chronic conditions has been normalised, why is self-management of a pessary so problematic to women? And this lack of evidence regarding what affects willingness to self-manage a pessary means that we can't understand what support may better help women to feel able to self-manage their pessary. And therefore I applied for funding from the NIHR and have undertaken my PhD to look at this. As part of my mixed method study was via questionnaire. So 89 pessary using women completed a questionnaire. 33 of them had previously been taught pessary self-management. However, of the remaining population, only 21% were willing to learn. So for the first time, we had rigorous data about the levels of willingness to self-manage a pessary in pessary using women. We also looked to see whether there were any factors that predicted willingness to self-manage a pessary. My hypothesis was that female genital self-image may be correlated with willingness, and we found that there wasn't any relationship, which is interesting in itself. The only factor which was associated with willingness to self-manage a pessary was age, with younger women being more willing to learn self-management. However, we didn't know why this would be the case, so therefore we moved on to the next stage of this mixed methods project by undertaking qualitative data collection via interviews. But as part of the interviews, women highlighted that factors which facilitated pessary self-management included their perceived self-efficacy, understanding the benefits of self-management, and having previous experience using different intravaginal devices. Women shared that their concerns about self-management were pessary insertion or removal being painful, the availability of ongoing support, the possibility of forgetting to remove the pessary and being lost to follow-up, the physical requirements required to insert and remove a pessary, and also the fear of not doing it right. Women highlighted that even if self-managing, they desired scheduled face-to-face appointments and vaginal examinations because they found these reassuring. Women also felt that self-management support should be personalised and normalised touching of the female genitalia, as they felt this had been hypersexualised within our current society. Women also emphasised the importance of peer and professional support. And interestingly, one woman suggested reviewing the term self-management, as to her this denoted complete independence, which she didn't want. I then moved on to a creative aspect of my research. So I used embodied inquiry, which is a creative approach of looking at problems in different ways. So where there's an embodied experience, it suggested that using non-verbal ways of undertaking research may be beneficial because women can find different ways of expressing their embodied experience. And I hypothesised that this may be particularly beneficial to this subject area due to the taboo nature of prolapse and pessary use, which may make it more difficult for women to verbalise their feelings. So 5 women created an identity box about how they felt as a woman who with a prolapse or as a woman who used a pessary. And you can see one example of one woman's box here. This was the first box, and when I received it, I was really excited because I knew I was onto something. So the themes that were identified through the different identity boxes were female identity, prolapse symptoms, strength, support, and a beautiful life after prolapse. Participants clearly valued pessary management and the positive impact it had on their life, and this was reflected in the images and words used representing pessary care. 5 images representing each of the themes was created by an artist to ensure creative dissemination of our findings in accordance with the ethos of this creative work. And we do believe this is the first time creative methods have been used to explore the experience of pessary using women. So here's one of the images that my wonderful artist created. So this was the theme of female identity. And this demonstrates about how women shared how they were balancing a tightrope of different areas of female identity in general. So you've got body image, traditional female roles, sexual identity, academic and work success, as well as surviving abuse. And then in the center of the image, you've got being a pessary patient, which is how women described it. And you can see the ivy, which is linking from being a pessary patient to all the different areas of women's identity, and then linking back. And that was because we realized there was a reciprocal nature between different components of women's identity and being a pessary patient. So both impacted upon each other. I moved on to the final area of my research, which was co-creation, which describes the exchange of knowledge, skills, ideas, and experience between different stakeholders with the goal of meeting the needs of a population. So 8 pessary-using women took part in 2 virtual workshops, whereby research findings were discussed and strategies for improvements workshop. These are the strategies that were co-created by women. I'll just share them with you briefly. So with regard to concerns about physical requirements affecting willingness, women suggested we needed to look at developing a pessary applicator and having wider access to soft pessaries made of silicone, as these were perceived to be easier to insert and remove. Knowledge and understanding was also highlighted, and therefore women desired evidence-based, high-quality written information at all of the centres. With regards to social support, women desired better professional peer support, and therefore we looked at establishing online and face-to-face peer support networks. And also the need for ongoing support as well as ad hoc support in case of pessary problems was highlighted. Women desired better support for emotional components of having prolapse and self-managing a pessary. Therefore, this needs to be incorporated into self-management support. And perceived self-efficacy, as I mentioned, affected willingness. Therefore, it was suggested that we need to include this as part of self-management support. Finally, women suggested that we needed to convey a positive perception of pessary self-management by reframing it as a positive option, not as women being fobbed after finally getting into the system. We should do this by emphasising the potential benefits of self-management, as well as undertaking work to explore rebranding pessary self-management, starting with a new name. In conclusion, willing to self-manage a pessary for prolapse is complex, and this research demonstrated that different factors impact differently on individuals. Therefore, a holistic approach to discussing self-management is necessary. Further work to follow on from this PhD would be to look at the lived experience of women and how this impacts on willingness to self-manage a pessary. Establishing whether peer support for pessary using women would be clinically and cost effective in terms of enabling a greater number of women to feel willing to self-manage a pessary. Looking at developing a universal pessary applicator and improving the experience of pessary care for women so that they don't have a negative perception of pessary care and therefore pessary self-management by the point they get to that. So in terms of translating these into into difference in clinical care, I'm meeting with NHS England's Women's Health team at the end of July, with the hope that we might be able to implement some of these. Finally, my goals of presenting here today were to share my PhD work, to introduce and promote our urogynecology department, the Warrior Unit, which, as Fiona mentioned, is the largest urogynecology department in the country, and we are an extremely research active team. To identify and engage with potential academic partners and build collaborative networks within women's health research. Key research areas for collaboration, both for myself and the wider department, are pelvic floor dysfunction, conservative management of pelvic floor dysfunction, supported self-management, broader women's health initiatives, and inequalities in women's health. And I would welcome if anybody wants to get in touch with me about working together on any of those areas. Thank you so much.
Thank you very much, Lucy. That was a fantastic talk and well kept to time. What we're going to do is we're going to move on. So if there are questions that spring to mind, please do put them in the chat. Lucy will respond to them and we will have a session at the end to look at some of them, hopefully all of them. But in the meantime, we're going to move on and I will introduce our next speaker, who is Dr. Annemarie Money. Dr. Money is a research fellow for the National Institute of Health and Social Care Research for the Applied Research Collaboration in Healthy Aging. And her particular interest is in looking at barriers to the use of localized treatment for recurrent urinary tract infections in postmenopausal women who are living in care homes across Greater Manchester. And that's what she's going to talk to us about today. So in the interest of time, I will hand over to Annemarie. Thank you.
Thanks, Fiona, and thank you for the opportunity to come and talk about this today. I hope everybody can see my slides okay. So as Fiona said, I'm Annemarie Money. I'm a research fellow in the Healthy Aging theme of the Applied Research Collaboration based at the University of Manchester. And just to say quickly, one of the aims of the ARCs are to respond to and meet the needs of the local population and the local health and care systems. And the Healthy Aging theme has very close links with local partners, and we work with them to co-produce research that will help older adults in Greater Manchester to live longer, healthier, more socially connected lives. And it's through those connections with the Greater Manchester Menopause Network and some other local contacts that this work came about. Okay, so I just thought it would be useful to put up a list of the collaborators in this work to date. So we've got a number of academics and researchers from a number of different universities. We have some PPIE representatives who've helped us with this work, local care home representation, as well as national networks such as the NIHR Enrich network, specialist menopause GPs, and we have support from the Greater Manchester Aging Hub in the Combined Authority. So just to give a little bit of background to the issue, as many of you will be aware, a urinary tract infection, a UTI, is a bacterial infection in any part of the urinary system, so the bladder, the kidney and the urethra. And it's caused by bacteria entering your urethra through, entering your urinary tract through your urethra. And this is the tube that carries urine from your body. And UTIs are one of the most common problems that GPs see in their practice, and they're generally pretty easy to deal with. However, if they do go untreated, they can lead to some quite serious issues, serious infections like sepsis. And then in terms of older populations, we are interested in terms of healthy aging, they can lead to falls, worsening of dementia, hospitalisation and death. And a recent report looked at a 5-year period and found that 1.8 million admissions to hospitals for UTIs were made over a 5-year period from 2018 to 2023 at a cost of around £400 million to the NHS. And in an effort to address this, the UK Health Security Agency launched an awareness campaign in 2023. Targeted at older people, care homes, carers and health professionals to raise awareness of those behavioural and hygiene measures that should be put in place to try to prevent UTIs occurring in the first place. And one of the reasons that this was focused on older adults and care homes is that of those 1.8 million admissions to hospitals with UTIs, over 60% were in adults over the age of 65, and patients aged between 80 and 84 made up the highest proportion of those older adults. UTI rates were also higher in frail older adults, those with diabetes, and in women more than men. So although men and women suffer from UTIs, generally women suffer a bit more. So this image shows a ratio of 8 UTIs in women compared to 1 in men. Some sources would put this much higher, at about 30 to 1. But what we do know is as women age, so does their increase in UTIs. And as well as UTI rates increasing, women are also more likely to suffer from recurrent UTIs. So this is defined as having 3 or more UTIs in a 12-month period. or 2 or more in a 6-month period. And they're more prevalent in older women over the age of 45 due to the hormonal changes that happen at this time, the onset of perimenopause and going through the menopause. And as you can see from that table, recurrent UTIs are just one of the issues caused by or kind of bound within this genitourinary syndrome of menopause, GSM. And these GSM refers to a range of symptoms that are primarily caused by low estrogen levels. And studies have shown that 70% of women over the age of 75 have GSM symptoms, but only around 7% have any treatment for these. And in terms of treatment, for UTIs more generally, these have traditionally been treated with a course of antibiotics. Obviously, this comes at an additional cost to the NHS, and also it has an impact on antimicrobial stewardship and overuse of antibiotics, which is an issue within care homes particularly. So antibiotic overuse drives resistance to antibiotics, which reduces the ability or the availability of treatments for infection when people really need them. And some studies have estimated that antibiotic prescribing for UTIs in care home residents accounts for between 29 and 66% of all antibiotic prescriptions. In terms of recurrent UTIs, the recommended treatment is localized estrogen. So this is a topical form of the hormone estrogen, which comes as a tablet, a pessary, a cream or a gel or a vaginal ring, and it's applied or inserted directly to the vagina. And this is different to traditional hormone replacement therapy, so HRT, which is systemic and goes into the bloodstream. So localized estrogen is topical, only a minimal amount is absorbed, and there's very few health risks or side effects. So in December last year, the National Institute for Health and Care Excellence updated their guidance on recurrent UTIs and recommended that if those behavioural and hygiene measures that we saw in that poster earlier had been met, then for women who were experiencing perimenopause or were postmenopausal, then localised estrogen is the recommended treatment. And I'm not a medic, so excuse my explanation, but I think simplistically, as hormones levels decrease during this time, the urinary tract lining gets thinner and it reduces the body's ability to fight bacterial infections. Localized estrogen works to improve the bacterial flora, to reduce the pH value, and to improve the muscle tone in the vaginal wall, and all of these kind of help reduce or fight bacterial infections. So there is evidence to show that it is effective in reducing the incidence of UTIs, alleviating discomfort, and actually as a cost-effective alternative treatment to antibiotics. So what is the issue then? So despite the nice guidance and the evidence that we have, the treatment or the uptake of the treatment for helping with recurrent UTIs and other aspects of GSM is low in women across the board. And then anecdotally from discussions with people in care home organisations, for postmenopausal women in care homes, the uptake is very low. So with the help of a health economist at the university, we had a look at prescribing data for Greater Manchester over a 3-month period last year. And this showed that less than 5% of women aged 45 years and over in Greater Manchester had been prescribed this treatment. So with this in mind, we wanted to plan a small-scale study to be undertaken with health and social care professionals to understand what the barriers are to this pathway. And we plan to interview a number of care home staff members, care home managers, GPs, nurses, around their levels of knowledge around this treatment pathway, what they think the particular barriers might be, and what we could put in place to improve this in Greater Manchester. So anecdotally, we know that there might be a number of barriers at play. One of these is around a lack of knowledge. We know that there's a lack of health professional knowledge around the issue of GSM and the impact that the depletion of the hormone oestrogen can have on women's health. There's also the possibility that there are legacy health warnings. So some of the patient information leaflets in some of these products, they're outdated. They still refer to side effects and health risks that we now know are not linked to localized estrogen, but they haven't been updated. We saw that there are a number of different products. So there's creams, there's pessaries, there's rings. Each one has a different dosage, a different method of application. So that confusion might be adding to this as well. There might also be a barrier around consent to treat, particularly within a care home setting with older women who maybe have cognitive impairment or dementia. And that might be more of an issue for residential rather than nursing homes. We just don't know yet. And just more generally, research has shown that the attitude to GSM amongst some healthcare professionals is that it's a natural and unavoidable part of the aging process, and we just have to get on with it. We just have to endure it. So these kind of wider societal beliefs around women's health might also be a factor. And there will also be other barriers that we will uncover when we do this work. So where are we at currently? We have ethical approval from the University of Manchester, and recruitment emails have gone out via the NIHR Enrich network and some local Greater Manchester contacts. And the plan is to start data collection in the next few weeks. And we believe this study, whilst it's a very small study, is an important first step in identifying the blockages along the care pathway, which are acting as barriers to this treatment. And understanding these issues from a health and social care perspective in the first instance will allow us to plan future work with older women within the care home setting, but also women in the community for, this is a problem for women across the board. So in the short term, it has the potential to improve the quality of life for women experiencing recurrent urinary tract infections. In the kind of medium to longer term, it could have wider impacts on prescribing practices, women's access to healthcare, hospitalizations, hospital costs, and so on. But this is very much the first small step in this larger programme of work that we want to do. So I shall leave that there for now. I'm happy to take questions at the end.
Thank you so much. That was really interesting, and there are lots of questions that I'm thinking of anyway. Oops. And you kept time. That's the timer. So thank you very much. We're going to move on to our next speaker, who is Dr. Karolina Stepien. And she is a consultant in adult inherited metabolic disease. But not only is she's also a researcher who works within the NIHR Research Delivery Network. And she is going to talk to us today in particular about how rare inherited metabolic diseases affect women and how they affect women differently. And what it means for the diagnosis, their care pathways, and also lifelong support. So I'm going to hand over to Karolina to hear her talk. Thank you, Karolina.
Yeah, thank you for your kind introduction. So I'm based at Salford Royal, and my special interest is hormonal dysfunction in adult patients affected with rare metabolic conditions. So given that the cohort of patients transitioning to adult metabolic care has increased over the last several years, the larger proportion of female patients has been diagnosed with endocrine problems. And it led to establishing a new service approximately 7 years ago, a joint endocrine metabolic clinic, which I worked alongside Professor Mukherjee and now Professor Adrian Hild. And so I would like to present 3 short overviews of a project which originated from this service development. So the impact of of the menstrual cycle on the amino acid disorder phenylketonuria, diagnosing early stages of premature ovarian insufficiency in a sugar disorder galactosemia, and the most recently completed project, long-term outcomes of pregnancies in women with cobalamin deficiency, which is B12 metabolic pathway, with a focus on in utero treatment. So starting from the first project, PKU is an amino acid disorder, and it's diagnosed in all patients now via newborn screening. And as long as the patients remain on a strict low-protein diet, the outcomes are generally positive. The focus of the last few years, the focus on research was on a maternal PKU, because if the mother does not comply with the diet, the outcomes to the offspring have been detrimental. Some women, however, women with PKU report that menstruation causes a higher level of phenylalanine levels, so amino acid in their blood, and it may lead to some challenges from healthcare professionals about their dietary adherence, their compliance. They have also reported increases in blood phenylalanine level at the onset of menstruation, which might have also masked the responsiveness to sapropterin, one of the drugs for PKU. However, there's no scientifically recognized evidence that the menstruation affects blood phenylalanine level in PKU patients. And in one of the recent studies from 2018, Draper et al. Have analyzed the levels of amino acids in non-PKU patients and the impact of the hormonal changes throughout the menstrual cycle on various amino acids levels, and they noted that some amino acids concentration can be much higher during the menstruation, while it decreases during the luteal phase. The reason for this fluctuation, for this difference, is not completely clear to us, and establishing fluctuation in blood phenylalanine in female with PKU is very relevant for their clinical implication, for their management and long-term monitoring. So it's very relevant for them. Now, I would like to touch on two studies initiated by Professor Vardy, who works with us at Solve Trial. One of the projects is a systematic review aiming to provide us with some answers about the mechanisms of hormonal changes and the impact of the hormonal changes, fluctuations on the phenylalanine levels in young females with PKU. It will also allow us to identify gaps in our knowledge and hopefully generate further research questions. The next study is a feasibility study, and it's fully funded by a patient organization, charity NSPKU, and we hope to start this study at the end of this year. We hope to recruit up to 10 female patients from our metabolic clinics at Solve Royal, and female patients will be asked to monitor the phenylalanine levels at particular time of the month, and they will be asked to complete dietary questionnaires to see if any changes in their diet impact phenylalanine levels, and they will be also asked to complete another questionnaire about their overall views, whether the hormonal cycle and the day of the cycle has an impact on the metabolic control in general. Now, moving on to another condition, galactosemia. So galactosemia is one of the commonest rare metabolic conditions. It's a defect in a breakdown of galactose, mainly coming from exogenous sources, from diet, from dairy products, from breast milk. And the galactose and metabolites build up in liver, kidney, and also cataracts early after birth. So in some countries, there's a newborn screening available to diagnose galactosemia early in infancy. However, in other countries where the newborn screening is not available, babies usually present with acute illness and are diagnosed in the first few weeks of life. And as soon as they are diagnosed, they follow dairy-free diet and galactose-free diet lifelong. And this is mainly to minimize any long-term complications, in mainly CNS-related complications. However, most women with this condition, they develop premature ovarian insufficiency, which results in subfertility, so they have a delay in conception, or they have infertility. And we know from some individual cases that children, babies with galactosemia, they have eggs present in their ovaries, but the number of these eggs decreases over time. And girls going through puberty very often require hormonal treatment to kickstart ovulation. We don't really fully understand the pathomechanisms behind it. So one of the studies I completed in collaboration with the Irish group was a study looking at expression of particular genes, genes responsible for glycosylation, and we found that some of them are expressed more and they are linked with inflammation and also glycosylation pathway in females with galactosemia. In addition, we also found that the abnormal glycosylation may lead to systemic signaling abnormalities and dysregulation of the leptin receptor, and the work is still ongoing. But in the meantime, we've started working on another project jointly with the Manchester Metropolitan University scientists group, a project looking at microRNAs and the expression of microRNAs, small particles which are present in the blood of female patients with galactosemia, and we plan to compare the expression of initially identify these microRNAs and then compare the expression with age-matched controls. We know that these small molecules, they can be expressed and they are linked with particular pathways, and we are planning to look specifically at the subfertility pathway, inflammation and glycosylation pathway. So as part of this project, we plan to collect samples as part of the metabolic biobanking, which I lead on at Salford, but the plan is also to approach younger patients, children from the Children's Hospital, as we know that they will be coming through the transition at some point, and the plan is to follow up and monitor the pattern of microRNAs from childhood, adolescence to adulthood in these patients. So as currently there are no biomarkers available to follow up the hormonal and fertility problems in these patients, we hope that the next few years will help us identify certain tests which can be used as biomarkers for monitoring for a prediction of premature ovarian insufficiency in this group of patients. On a different note, there's also work done with Galnet Registry, International Galactosemia Network, international group, and we are looking at different biomarkers at the global level. Now, moving on to the last condition, this is the most recent project we completed and has just been submitted. So we looked at late onset cobalamin C cases. Cobalamin C is one of the genetic remethylation disorder. It's deficiency in methionine synthase, and without going into details, biochemical details, we know that there's a deficiency of methyl group, which are needed for myelin formation, for creatine synthesis and DNA methylation, and which are so important for the CNS function. And Cobalamin deficiency is a multisystemic condition with variable presentation, and we specifically looked at cases diagnosed later in their life. The management strategies and pregnancy outcomes in affected women remains very poor, limited, and moreover, the long-term outcomes following from prenatal diagnosis and treatment of affected fetuses, babies in these women comes only from very sporadic cases. So with the International EHOT group, International Homocystinuria Outcome Group, we identified women who were affected with cobalamin deficiency and who were pregnant, had documented pregnancy, and we follow up them and their babies. And we also looked into women who had the first baby severely affected or who passed away, and then they had subsequent pregnancy, and they were managed early in the pregnancy with hydroxycobalamin replacement at different doses. So in terms of the first group, where the women were affected with cobalamin C, 3 out of 8 offsprings showed mild growth impairment, but otherwise had normal development. We also contacted the authors of cases previously published. So children are now 20, 30, 40-year-old, and they are completely well. And we know that hydroxycobalamin administered at various doses between the week 5 and 31 had no teratogenic effect. Some of these women were also on betaine. Betaine helps remethylate methionine to homocysteine. And all the prenatal cases had ameliorated phenotypes. So the sooner they were treated, the higher dose of hydroxycobalamin, like 1 to 3 milligram daily, they had no microcephaly, no epilepsy, and no multi-organ failure. And again, some of these children are 3, 5, or 9 years of age. So these findings suggest that prenatal diagnosis and therapy may ameliorate the neurocognitive impairment, but only partially mitigate the ophthalmic complications, as these children, there's some evidence, may still develop maculopathy in their 2nd or 3rd decade of life. So in summary, the impact of hormonal fluctuations during menstrual cycle impact the metabolic control in PKU. MicroRNAs are potential biomarkers of subfertility in classical galactosemia. There is a need for standardized methods of early diagnosis, introduction of therapy in pregnancy, and to improve the long-term neurological and ophthalmic complications in females with cobalamin deficiencies. And women with inherited metabolic diseases require a long-term follow-up in our joint endometabolic clinic to address their complex clinical needs. And I would like to thank my collaborators on various projects. And first of all, thank you to Professor Vardy.
Thank you very much. That's a fascinating talk, and we've got such a variety of talks and subjects to cover. If I could ask all of our speakers now to join us for the Q&A. If you can pop your cameras on, fantastic, thank you. So in terms of some of the questions that we've had in the chat, the first one, Lucy, I wanted to ask you about, because obviously we've just heard about different talks. We've heard about vaginal pessaries for treating recurrent UTIs, and we've also heard about pessaries for prolapse. Now, they are completely different things. Do you think we have a problem in calling our devices for prolapse pessaries?
Yeah, I definitely do. Obviously, I've been on a long journey in terms of my PhD, and I discovered a couple of weeks ago that my dad thought we were talking about medicinal pessaries in terms of the things that people use for thrush after all the conversations we've had about it. So yeah, I do think it's really problematic. Unfortunately, I think mechanical pessaries are problematic. I've been involved in some conversations with the MHRA about the regulation of mechanical pessaries and the registration of them, and not getting anywhere. So while I think that the name doesn't help, I think that there's a lot of other problems in terms of how we use pessaries. And for a couple of years now, I've been saying that I feel like pessaries are going to be the next mesh scandal of urogynecology, in the sense that, you know, there's no regulations about who can insert them. In some centres they're done by support workers. Whether they're appropriate professions to do it, how long they can be in for is really difficult to determine. So I think that there's a lot of work that needs to be done to ensure that pessaries are used as the safe and effective product that they are.
Thank you, Lucy. Annemarie, somebody has asked about whether or not the oestrogen has to be a pessary, or can it be, or locally applied, or can it be actually a systemic tablet or patch, or...
Yeah, I mean, they're two different things. So hormone replacement therapy, and obviously I'm not a medic, so somebody might want to correct me, but hormone replacement therapy, so, you know, the progesterone and the estrogen that we take via tablets or via gel, that goes straight into your bloodstream. That's different to localized estrogen, which is applied directly to the vagina. And it works, as I said, on different... the pH value, the muscle tone, the bacteria within the vagina and the vaginal wall. So it is different to, and you can use both at the same time. But yes, it's different to systemic HRT. This is a topical form of estrogen. Yeah.
No, exactly. I would agree with you entirely that and for GSM, it really does need to be the vaginal. It's the topical and often, because we find in clinics in our urogyny practice that we're saying to patients, yes, I know you're on HRT, but you do actually need to use this. And that's where we run into problems, because there's an awful lot of people who seem to not be very happy about the fact they have a vagina and that they might need to touch it. And we see, you know, I think it's a huge area that's underexplored. Right, Lucy, somebody asked, how do you actually diagnose a prolapse?
Yeah, I was just answering in the chat. So, Adela, it's a really good question. Like I was saying, it's really prevalent. So we think about 50% of women who've had a child will have anatomical prolapse, in the sense that if we measured it, that we would see it. But we only need to worry about it when people start to be bothered by their symptoms. So the symptoms that women frequently report are awareness of a bulge within the vagina, or a dragging or a heaviness sensation, and that's the prolapse coming down. So we sometimes have women who come to clinic and say that they're aware of this, but they're not bothered by the symptoms at all, in which case sometimes that's sufficient to reassure them that that lump isn't cancer or something like that. But for other women, they do then want to go ahead and have treatment, whether that's pelvic floor muscle exercises, surgery, or a pessary. So it's very much guided by the woman and how much her symptoms bother her.
Until we get some research to know actually why prolapse occurs, and, you know, should we be intervening early and all that kind of stuff. It's incredibly under-researched. Alex is asking you, does this apply to women who've had a cesarean section, or is it just those that have had vaginal births?
So some women who have never been pregnant develop prolapse, and that's because there's probably a weakness in the pelvic floor muscles, that means that they can't, or like a connective tissue disorder, or they might have other factors such as being overweight and the increased strain that puts on the pelvic floor muscles, or having a chronic cough or chronic constipation. All of these are factors that increase the risk. Having a cesarean section does reduce the risk of developing pelvic organ prolapse compared to vaginal delivery. Obviously, it comes with other risks separately, and there are certain things that happen during delivery, such as forceps delivery, which again increase the risk of developing prolapse. So there's lots of risk factors. So in terms of obstetric risk factors, non-obstetric risk factors, but unfortunately for some people, they do just have they're more likely to develop it either due to some genetic component or something like that.
Thank you very much, Lucy. Karolina, can I ask you, how do you cope with funding for when you've got such rare disorders? You know, do funders kind of, we've got the extremes, we've got prolapse, which seems to affect everybody, and we struggle to get any funding for it. And then you've got conditions that are affecting tiny numbers of people. So how do you tackle that?
This is a very good question. It depends on how the prevalent or common the disease is. So we are lucky, as in terms of PKU or galactosemia, there are patient organizations and in the UK or also international groups, and we can apply for funding. And we had grants from NSPKU, from Galactosemia Foundation to continue our studies. But I agree that in terms of NIHR or MRC, it's very difficult to secure funding for rare diseases.
Right.
And the other thing is, if there are therapies in development, we can also apply for commercial funding.
Right. Thank you. Thank you very much. We've got a comment from Jan, who's talking about the provision of incontinence pads. Now, there's a controversial topic as well. I don't know whether, Annemarie, whether you want to...
I was just trying to reply then. Not that I'm aware of, but other people on the call might know. I would imagine that's something to do with the provider, the care home. It costs an awful lot of money, incontinence pads, and obviously incontinence and UTIs and other issues with GSM are huge issues within the care home setting. But why that would just be 3 a day, I wouldn't know. I don't know if anybody else can add.
There are limitations. There are strict limitations on what can be provided, and it does come down to cost and resources, and probably the lack of society's understanding of how devastating incontinence is. And yeah, hopefully through meetings like this, we'll be able to raise the profile and hopefully, people will realize that they will become the person in the care home sitting in their urine, and they really need to get some research done in the next 20 years before it happens to them. But yeah, a squishing noise from the vagina. Is a squishing noise from the vagina a symptom of prolapse? Lucy.
You're going to answer that then, Fiona.
No.
As my consultant colleague. I think it's a bit difficult to say exactly what's going on, but it may be that there's some air in the vagina, and therefore that's what that noise comes from. So we do sometimes get women report that as a symptom if they feel that their vagina is lax, for example, particularly after they've had a child, or maybe some perineal trauma during the delivery. So it's difficult to say just from that noise whether that is a symptom of prolapse. But what I would say is that anybody who's got concerns that they might have symptoms of pelvic floor dysfunction, so symptoms of prolapse, symptoms of urinary incontinence, symptoms of fecal incontinence, you need to go and speak to your GP, because there's so much that can be done. And a lot of the reason why people live with their conditions for a really long time is because they think it's an inevitable consequence of having a child or aging. And there's so much that we can do surgically, conservatively. We just need to know about you so that we can see you.
Thank you very much, Lucy. We've got another question for Karolina about how do you diagnose the late onset, I'm not going to pronounce that correctly, am I?
Cobalamin
deficiency, yeah.
Well, actually, the project which we've completed after a few years, it was initiated after we had one case, late onset cobalamin C, and it was a sudden onset presentation with neurological decline and psychosis, and it led to obviously neurological workup, initially psychiatry review, and then subsequently metabolic workup. So we diagnosed it by running the metabolic full panel test, which I'm not going to discuss in detail, but very often people think about common causes of psychosis, right, or neurological presentation, like a stroke-like episode, considering neurological complications, then psychiatry, and as the last resort, metabolic causes.
Right. Thank you very much. Being a clever doctor is the way you diagnose it, I think. Right. Do we have any other questions or any comments that any of our panelists want to make? But a question for Annemarie. What about females that have had past history of estrogen, breast cancer? Sorry. Okay. So yeah. So this is about the use of localized estrogens in people with breast cancer.
Again, I would I would just state I am not a medic, so that you should speak to somebody that knows this in a bit more detail. But I believe that localized estrogen, in terms of the kind of risk factors and that for people that have had breast cancer, it's very low. Go and check with a proper
it's a balance. Yeah, it's a balance of risks. You're right, Annemarie. It depends how bad your GSM is. I mean, some people can have the most horrendous genitourinary symptoms, and what we often do, we tell them to have a chat with their oncologists, but it's a balance of risks. And often, if you use vaginal estrogen for 4 weeks, the chance of that having an impact on your breast cancer is quite, tiny, but you can never say never in medicine. But it is, yeah. And some breast cancers it won't affect at all. So other things like risk of clotting as well and stuff like that isn't a problem. And that is part of this leaflet problem, isn't it? That the leaflet, if you open the leaflet in a packet of vaginal estrogen, you'd never go near the stuff. It's terrifying. And it's wrong. So I'm very impressed to hear that you guys are tackling that, and it'd be lovely to see that leaflet rewritten, but I don't know whether the drug companies will do that. I don't know.
Yeah, we have Dr. Zoe Hodgson, the specialist menopause GP, who's kind of looking into that aspect of it. And I know that you can apply to the MHPR, the Medicine Regulatory Agency. So I'm not involved in that. I just know that that's something that is going on within kind of Greater Manchester, and people are working on that.
I mean, you would think that some of the organisations, people like the British Society of Urogynecology, would be people to contact, or the Royal College of Obstetricians Gynecologists, get the weight of them behind it. And because it is nonsense, but yeah. Okay, right. We are into our final 2 minutes. So I think it really is time for me to say a huge thank you to our speakers. It's been really interesting, and it's so great to hear the amazing stuff that's going on in Manchester. Michael, could I ask you to put up the final slide that says thank you? Yeah, honestly, and thank you to Lindsay and the BRC for organising these sessions. I think they're going to be a real platform for us to all get together and improve women's health in Manchester. You've got the opportunity to come to another 2 sessions next week on cancer and chronic disease prevention and management, and the final one on the health policy and prevention. And then obviously in July, we've got on the 9th of July, the public health showcase. So hopefully people will be able to meet in person, which will be amazing. So thank you very much. I think that wraps it up, and see you next week.